In today's program, we are going to talk about new paradigms in the treatment of obesity. To do so, we are joined by Fabiana Muen. She is a medical specialist in endocrinology and works at the Itaraspe Hospital and at SEMA. She is also a professor at the Faculty of Medical Sciences of the National University of Littoral. Fabiana, welcome to the program. Hello, thank you very much for inviting me. Well, first of all, let's define what obesity is, what characteristics it has, and when it is diagnosed, let's say. Well, to start with, obesity, which is something that sometimes not everyone is clear about, is a disease, a chronic disease, right? A chronic non-communicable disease that falls into categories such as diabetes, hypertension. Obesity is one of these diseases and appears when adipose tissue or, well, fatty tissue accumulates in the body, and this accumulation has an impact on a person's health. Yes, that is obesity. It is a very, very heterogeneous and complex disorder, both in its causes, in its pathophysiology, as we call it, as well as in its management. Yes, it has always been there. Okay. And what are the causes that generate it? Well, the causes are endless. We could say, they are multiple. It is a disease of multifactorial origin. They have an impact, well, on genetic issues. Cases that are purely genetic are rare, but there are some syndromes in which obesity or overweight manifests itself from the first years of life. But then it is, what is traditionally known, let's say expending little energy and ingesting a lot, but that is, let's say, the basics. Yes, let's say it exists, but it has many other aspects. There is the emotional part, the issue of stress, the issue of drugs, medications that are consumed for other health reasons that affect weight. From, let's say, sleep schedules, hormonal problems and, well, especially habits, what we also call hedonic factors, which are, let's say, social issues, having a lot of availability. Sometimes it happens to us that we are at an event or, I don't know, at breakfast, at a hotel, and we have a lot of food to choose from and we eat much more than we would normally eat because we have it there. Or the stimuli when passing by, I don't know, a bakery and smelling bread, even though we don't feel like eating. Those are all hedonic issues. That's why there are, many, edges, in addition to all the organic issues, let's say, neurotransmitters, that is, from the brain, the intestine, the liver, and a lot of endocrine organs are involved in this. Sure, that's what I was going to ask. That is to say, there is also a predisposition on the part of the person to or being more exposed to that disease. In other words, we can all have this disease or those who are more likely to acquire it. Well, yes, everyone, to begin with, we can all have this disease. Those who have a genetic predisposition are more likely to have it, those who have several overweight or obese people in their family, and, let's say, those who are in an environment that is, let's say, obesogenic, let's say, where they have, culturally, different types of diet. And well, also, let's say, social and cultural, types of work, those who are more sedentary, let's say. There are a lot of, situations that make there more of a predisposition. There are some pathologies that can have an impact, which, perhaps, are more what is thought. No, I don't want to say myth, because it is not a myth, like, for example, thyroid problems, which are very common, which have to do with the body's energy expenditure, with metabolism, with, let's say, a question of, expending more energy. So, let's say, hypothyroidism would contribute to this. Let's say, it has been observed that people with significant obesity have a higher incidence of thyroid problems and vice versa, but it is one of those thousands of factors, let's say. It is rare to see a person who only has a significant problem of being overweight or obese because of thyroid problems. Of course. And what are the risks of this disease? Well, there are also many more than people think because, well, most people think of diabetes, cholesterol problems, triglycerides, which is real and the risk is high. But well, even without these problems, there is already a greater risk of cardiovascular disease, a greater risk of hypertension. There are problems in the reproductive sphere, let's say, in both the female and male gender. They can hinder, let's say, fertility. There are problems. There is a higher prevalence of certain cancers in people with obesity. That has been demonstrated. Some already have a lot of evidence such as colon cancer, breast cancer, right? Those, let's say, endometrial cancer, which would be, let's say, uterine cancer, those types of cancers are seen more frequently in people with obesity. Well, and what is very important and that many times we, health professionals, leave aside, is the psychological and emotional impact. People who are obese and overweight have a high prevalence of situations of depression, anxiety disorders, significant depressions that affect their quality of life, which is partly due to the disease itself and what it causes in the body, but the social issue of stigmatization and blaming the person also has a great impact here. Exactly, because they have this disease, let's say, sure, I understand. And there is an age at which one can say, hey, I am at greater risk of getting this. Because, for example, a notable fact that is being discussed, that is being observed is that, there are many children with obesity, that is, it is a problem that is increasingly affecting children, that is, or that it is a disease that begins at an increasingly early age. Exactly. Let's say, leaving aside, as I said at the beginning, those genetic syndromes that are rarer, that have other issues and that are going to appear at a young age. What we see today is that unfortunately it is due to the paradigm shifts that force us, let's say, because when I was a child, let's say, playing on the sidewalk, running, going to the park alone, we didn't have access to screens, we didn't run to answer the phone because we didn't have cell phones. Well, today, logically, no one is going to let their sons or daughters go to the park alone at 8 years old because it is not done here or anywhere else in the world due to the risk it implies. The games have changed. It's more screen time, more sedentary lifestyle, and the type of diet. Let's say, the issue of home-cooked food, prepared at home, due to family organizational issues, due to rush, they end up eating processed foods that are not good for them, and that, well, everything leads to them being more enjoyable for the children who eat them. So they will end up preferring them to, for example, fruits and vegetables because they are more accessible to them. There are a lot of factors that also affect that. So, how can we prevent it in some way? I mean, since it affects us, right? Or as a patient, how can a patient prevent it, both for themselves and, well, if they have children, let's say? Well, the ideal would be to prevent it rather than treat it, to prevent it from happening. A lot of education is needed for this, and there is a lack of presence from the state, let's say, resources are poorly distributed. Every health center should have a nutritionist to educate the population, not to wait until the person is overweight or obese. To have a nutritionist come, but to anticipate this situation and educate in schools. At some point, it was decided to provide fruits in addition to what is usually available, but logically, a child who has to choose between a cookie and an apple will end up choosing the cookie. In other words, this would have to be addressed in another way, such as educating at home, at school, at work, and correcting habits and incorporating it. Even from infancy, the concept is in place that a person who is overweight or obese has to eat differently than the family does. Everyone should not eat the same thing. We all have to do physical activity. We all have to eat a healthy diet. There you can vary the portion a little bit and the quality of the food depending on your age. Sure. And avoid social situations that conspire against that, because every day you live, well, in general you live at 1000, so you usually solve your food with what's on the go. Let's say, you don't have time to cook, so you use multi-processed foods and so on. It also has to do with that, trying to balance external stimuli. Exactly, yes, and more than avoiding, which sometimes is hard for us because you say to yourself, oh, I have this party, I'm going to eat this. Well, that happens. It also has to do with education, knowing that you go to a place and can eat certain foods that you don't eat every day, but well, learning about the issue of quantity, to record what you eat. Another issue that has a lot of influence is that sometimes the amount you eat is the same, but we eat, I don't know, in front of the computer working our brain. It doesn't record that we are eating or I don't know, watching television and we eat without paying attention, no. You have to stop for at least 5 or 10 minutes, pay attention, taste, smell, and what our fellow nutritionists always recommend. Eat slowly and enjoy every bite of whatever it is, from a piece of fruit to a more elaborate dish. Yes, because that happens to us too. The brain doesn't register that we've eaten, and it's as if we hadn't eaten, and then we start eating again a while later. Sure, maybe I'm taking it off topic, but this whole intermittent fasting thing, for example, the amount of meals or the regularity of the intake during the day, that also has to do with it. It's always a good idea to consult a nutritionist before taking any kind of measure so they can suggest what to do. Yes, paradigms have changed in this regard, haven't they? When I started out, I've been a doctor for 31 years, it was like skipping breakfast was a deadly sin. Now we know that intermittent fasting is a tool. The thing is that you do have to do it under the guidance of a professional. We can't do it because of a video we saw on Instagram or because the neighbor does something and I go and do the same, because that can be harmful to our health. Intermittent fasting is a tool. The so-called ketogenic diets are also high-protein diets, but they have to be guided by someone who knows about the subject, which could be a doctor, a nutritionist or a nutritionist, let's say. Of course, especially so that it is tailored to the person who is consulting. And so that it does not harm their health, because sometimes we can do things that instead of helping us harm us or that cause us to lose weight, but then there are, let's say, more severe relapses. Or somewhat immediate magic solutions like surgery. Of course, right? Surgery is also a tool. I mean, all tools are valid. What we always have to keep in mind today in most health problems is that we are very individualized. Let's say, each person is different. What works for you may not work for me, whether it's dietary plans, types of physical activity, or types of medications, which we'll discuss in more detail later. Of course, surgery isn't for everyone. It's for a select group, but it's often a very useful tool because people who can't, let's say, control their obesity with other measures have to do so in order to avoid or improve all the complications we talked about earlier. Yes. So, these are all tools we have for treatment. Well, speaking specifically about treatment and the topic that brought us together in the interview, these new paradigms, what do these new paradigms consist of? In other words, what are the most salient characteristics and how do they increasingly differentiate them from previous treatments? In other words, how were they treated before, and how are they treated now? Well, before, as I said at the beginning, the approach was very simplistic. We used to say, increase expenditure and decrease intake, let's say, the scale and so on. That continues to be an important pillar. Without physical activity and a proper diet, none of the other treatments will work. Today, we have drugs that have been tested for several years, and some others that are new, which will complement the others. Yes. In our country, which is more or less similar to what we have in the rest of the world, we have several types of drugs. One of them, which has been around for several decades, is called orlistat. Yes, orlistat is a medication that acts in the intestine and prevents fat absorption. Yes, it reduces the absorption of fat in the intestine by approximately 30%. Yes. It has proven effective in terms of weight loss. It has side effects because, well, this will cause oilier stools, so to speak, and it can even cause diarrhea, what we call fecal urgency or incontinence, in some cases. Rarer, but sometimes they alter the person's quality of life, they can't leave the house. Other people tolerate it very well, that's why we said that each person is different. And the drawback, apart from those we mentioned, is that it can also, decrease the absorption of fat-soluble vitamins, vitamin E, vitamin D, vitamin K let's say. It can, cause vitamin deficiencies, which, could be solved by supplementing them. Those are, more or less, the pros and cons. They are capsules. This is taken by bioral and is taken with meals, let's say. That's the oldest one, we could say. Then, also in capsules, we have, here in Argentina, what is bupropion plus naltrexone. These, act mainly at the level of the central nervous system in the centers that regulate appetite, to explain it simply. So, it has an appetite-reducing effect, it improves anxiety. Yes. We always recommend that patients who are taking any other medication, such as psychiatric medication, consult with their treating psychiatrist to see if they can tolerate it. And if it has very few side effects. However, there may be headaches, dizziness, and in some cases, nausea and vomiting, like any other medication, have a low incidence of side effects. The other treatments we have are injectable. Yes, we have one that is a subcutaneous injection, and the person can administer it themselves. They don't need to go to a health center to have it applied. So, we have one that is a daily injection, liraglutide, which is a medication that was initially developed to treat diabetes and was shown to achieve weight loss. Therefore, they are now also approved for use in obesity, even if they do not have diabetes. Of course. And here we are talking about the pharmacological level, but it is also advisable to provide other types of support, physical activity and also psychological support from a professional. It is essential to approach a person with obesity in a multidisciplinary way. The treatment team must include a mental health professional, a psychologist, or a psychiatrist, because, as I said before, depression and anxiety disorders are very common, plus the burden of guilt, self-blame, and the stigma attached to others. So, it is essential because otherwise nothing else will work. Not the medications, not the diet, not the physical activity, if the person is not well prepared psychologically. Of course. Focused on Argentina, let's say how the problem is currently. Cases have evolved, they have decreased, there were peaks at times. Argentina, let's say, is no exception to what has happened worldwide in countries, more in some countries, less in others, but it is increasing due to everything we talked about before, more sedentary lifestyle, more technology, things like that. It is also accompanied by a cultural change or by a specific cultural and social reality, as well as types of work. Before, it was about going to work, let's say, now we have a lot of work, the famous home office, or the pandemic, for example, has also had an influence, There were many cases, a big increase in obesity during the pandemic. Well, in our country, for example, the National Survey of Risk Factors, which was conducted before the pandemic in 2018, shows that approximately 66% of people have an increased body mass index, that is, are overweight and obese, and almost 33% are obese.